Hello, and welcome to the Senior Portfolio Direct Restorative aspect. In this presentation, what we'll be doing is looking at specific coursework and clinical cases done and performed in the main clinic pertaining to direct restorations. Now, for your convenience, below this presentation is the exact PowerPoint that we're looking at. That way, if you would like, you can pause this video and review the slides that we'll be going over today. Any questions that you may have, please feel free to reach me by email provided below at j_barnett@u.pacific.edu. Thank you so much, and I hope you enjoy. So first case here, what we're showing is a case of a young lady that was my patient. Here you can see this was directly after a trauma that she had. You can see that she actually lost number 7 here. And then we have here a Ellis class 1 simple fracture, purely an enamel on number 9. So what we did here, this is just a before and an after. Here is just a nice class 4 that we did for her. Here you can see some really nice shade matching. I really do like the symmetry, the way that the light reflects here. If I was to be critical, I would say that here at the incisal embrasure, it's a little bit larger than I would have liked. Nonetheless, I think the shape is pretty symmetrical, and the patient was definitely ecstatic to have that. Now, what's not pictured here is for this patient, we did do many other fillings. We did do number 3, occlusal lingual, number 14, occlusal lingual, number 15, occlusal, number 17, number 18, number 19, occlusal, and a buccal class 5 on number 19 that are not shown here. And again, I do here have the bottom says, please download this file to see narrative of each slide in the comments section. Again, if that's too much, we do have this video, so any questions you may have, like I said, please feel free to reach me by email or download this. So here, this is the same patient. Now, after going through oral surgery, you'll see that we ended up going with a bilateral canine substitution on the patient. And you'll see here that here's that class 4 that we did, still holding up really well. This is about, I'd say, 3 months after. And so we fresh off the extraction post-operative of number 10. During the procedure, the operator did actually have some iatrogenic damage here on number 9. You can see the distal aspect. So this is just some patchwork that I did for the patient. That way she wouldn't have that crack there. This is a different case, and excuse me for the picture and the lighting. It was just saved this way to save room on the space. But this is just a filling. This is not my best work, and this was definitely a difficult case that you'll see more of. Here you can see that the patient really needed good disease control, which the patient and I didn't really get to go past the disease control, mostly due to finances and due to the patient's time and things like that. So here you can see the patient presented with a very large broken restoration here. You can see that there's recurrent decay here. So all we were able to do for the patient, because the patient was extremely sensitive, is we did dig out the decay here and we just patched here with GI. Again, this is definitely not ideal dentistry and definitely something we had to do in a pinch of time. But nonetheless, this is, again, just a GI restoration here, class 3 that you'll see. So this is the same patient, actually. The patient had very large restorations, composite restorations, all with recurrent decay. And for this specifically, he had number 9 that chipped, and then also there was also some chipping on number 8. So here what we can see, and this is number 10 as well. This is about 6 months after the slide before. You can see that my GI restoration did not hold up at all. And here, if you're wondering what this is, the patient does wear a acrylic stay plate that the patient believes are dentures, and so it was in the treatment plan to replace those acrylic stay plates for him at some point, but again, we didn't get to that. And so what we did here is took out all the recurrent decay. I do not have an intraoperative picture that shows with these large restorations out, but nonetheless, we took the restorations down completely. And here is what he ended with the large class 4s on number 8 and 9. You'll see that the patient actually did present with some spacing, some diastemas here between 8 and 9. And so we did close that gap, and I think that the symmetry is somewhat close. The patient was extremely happy with it. but truth be told, I wasn't extremely happy with it. I think there could have been a lot better of shade matching here, and just overall, I wasn't extraordinarily happy with it. I definitely think it was the most difficult, one of the most difficult things I did here in the clinic. And you can see that even though the patient's midline is off, I did set the midline right here with the philtrum of the nose here. So I was happy with that. And again, the patient was extremely happy, but this is definitely one of the most difficult things in my experience at dental school. And, I definitely, if I were to do that again, I learned lots of things on, for example, how I would wedge the teeth, my isolation, what I had a difficult time with. So lots of takeaways from this case, and I'd be happy to answer any questions that anyone may have for this. So here, this is a different case. Here, what we're looking at is number 2 and number 3 on a patient. Now, this patient is a 27-year-old and suffers quite a bit from pretty extensive caries disease. So here you can see number 3 presented with a broken MO restoration, amalgam restoration. And then here we just have really leaky separate occlusal amalgams on number 2. So what we did is these here are the preparations here. For number 3, we did see that there was decay straight to the pulp. So working with the faculty, what we just did is we cleared as much as we could, got some really clean margins here, and then we just threw that over with GI. This was my first GI filling where I actually had to create interproximal contacts, and I was pretty happy with what we were able to do. Again, you'll see here I used the Toffelmeyer. I'm a huge fan of the Toffelmeyer. I used that quite a bit throughout my experience at dental school. I just feel like even though I know that the Toffelmeyer is usually a suspect for open margins. Open contacts. I found that with really, really strong burnishing, I really didn't have that problem at all, even with the GI restoration. So here, again, this is the GI restoration, and then here, we were actually able to clear out all the decay, get it nice and ready for composite filling. And here's the final restoration for number 2. Here, this is the same patient. This here is number 14. You see here we had the MOD composite. Again, just old amalgams with lots of recurrent decay around them. So here is the intraoperative after we finished preparing. After this picture, we threw on the rubber dam, and then we ended here with the composite here, which the patient was happy with and had a really nice contact against number 15. Same patient again, so this is here number 30 and number 31. You can see here both have restorations on them. You can see that there's quite a bit of recurrent decay here on number 31. This is a really cool intraoperative picture that I took when I was preparing here on the distal aspect of number 30. I kept running into something that was going on here, and I was actually able to use the intraoral camera to get this. And this is actually a piece of calculus that I missed throughout the SRP, or excuse me, the prophy that I did earlier. And it really did actually impinge, my ability to adequately restore this too. So what I did is I stopped, went and got a scaler and actually scaled it off, and it really did provide a much easier, a workability for me in terms of restoring the tooth. So here on top, this is tooth number 30. Here on bottom, this is tooth number 31. Very similar to 2 slides ago. Tooth number 30 we're able to restore, and then tooth number 31 we actually had to, we stopped because we had caries to the pulp, and so we just threw a GI over it. Again, this is now my second GI class 2 restoration. I was really happy with actually the contact. It's more C-shaped than I would have liked, but nonetheless, patient was pretty happy with it. And again, if you look at it from a different angle, it's not quite as C-shaped as one would think. And then for number 30, you can see here we have the MODB. Turned out really nice. Again, really nice contact with 29. Did use the Toffelmeyer, like I mentioned. And yeah, I was really happy with the result, and so was the patient. So this is another patient. I do not have any preoperative photos, but he was one of my first I would call big restorative cases in terms of doing multiple restorations. So you'll see us talk more in the indirect video about number 3. This is the crown that I did for number 3. But here for the direct restorations, we tried to get as best of pictures as we could. So number 6, buccal class 5, number 7 buccal class 5, a separate MI class 3 on number 7 here. I did do, I believe it was number 8 class 5 as well, number 10 class 5, number 11 class 5, and here a number 21 class 5. You can see this was just post-operative of the number 21. Now the patient does take a blood thinner, and so he was actually really difficult to work on in terms of he would often, have lots of heme. And so it was really interesting working with this because I really had to find a way to work around that, and through using, for example, Lido with epi, using with one of my instructors, we did get the 1 to 50,000 epi, and that actually did help quite a bit with just a localized hemostasis, as well as just using the ferric sulfate. That helped quite a bit as well. But nonetheless, here's post-operative after I've finished all of the restorations, and the patient was fairly happy with the work that we did, and so was I. I learned a lot from this case, especially dealing with, like I mentioned, the bleeding. So again, another case where I do not have the preoperative. I would have loved having the preoperative because the patient had, in my short and limited experience, the largest abfractions that I've ever seen. They were non-carious lesions. They were just huge indentations. And on the x-ray, you can actually see quite a really big V-shaped inward toward the pulp. So what we did is, it was pretty much non-prepless. We just made sure that, we really put some bonding agent towards the bottom and kind of just close the dental tubules that way to, at least prevent or slow down the idea of dental hypersensitivity. And we ended up with class 5 restoration on here on number 5, on number 12, 13, 21, or 20, and 21. This was fresh post-operative of number 21. Now we did also do a number 29 DO on the patient, which you will see because this patient did have a crown on, we did a DO on number 28. And we did do a crown on number 29. So we will see what that contact looks like in the indirect video if you're interested in that. Here, if I was to be critical, I'm not particularly happy with the contour here. Granted, there is some gingival recession, so really at this point, this shouldn't be this shape. It's actually more towards the shape here on number 13 because we do have that high contour and then it does go down here. Nonetheless, I just feel like this is a little bit, not as smooth as I would have liked it to be. The patient is one of the patients who really does not care about aesthetics at all. You'll definitely see that during the indirect video. Nonetheless, I just would have been a little bit more happy with, a different turnout. But again, the patient was extremely happy, and this is a pretty close-up shot of the patient. So here, this is just a quick thing I added. I had this is a patient of mine and a classmate actually did root canal therapy on number 14, and this is actually between endo visits. So here you can see the endo access for number 14. Patient did present. I'm not entirely sure why they didn't remove the entire amalgam, because the patient did have an existing MOD amalgam, and so they just accessed right through it. And so, of course, the mesial portion of that restoration fell out because it had nothing kind of wedging it because the patient is a dentulous here in number 13 area. So the patient was worried about it. He came in and I just simply put some flowable into the area. I think it looks really good. This is just kind of showing the skill. This was only about 5 minutes. So this really kind of helped, just at least calm the patient. And it was good, good exercise for me to try and, really make sure that I know what I'm doing and getting a nice contour and color matching. So I was pretty happy there. This here is a class 4 on number 8 and 9. Again, I apologize about the way that the colors turned out. This is just for file size decreasing. So that's why you have these kind of blown out images. But nonetheless, the patient chief concern was here, number 8 and number 9. He did have a history where I suppose it was a crazy wild goose chase where some guy stole his truck and then he chased him down and they got in a fight and the guy actually punched him right here in the teeth. That's why he has these these chipped teeth right here on the incisal edge. Patient wasn't happy with it and just wanted to see if we could do something for it. So what we did is we just went out. It was non-carious, and she's just Ellis class 1 simple fractures. So what we did is went through, and I didn't bevel nearly as much as I would have liked to. Here we can see these photos here just from each side, and I think there's a really clear line as to what tooth is and what composite is. I definitely was not happy with the way that looked. The shape I was almost 100% happy with. I love the way it came out shape-wise. It's just, again, the color was really not what I was happy with. Now, you can't see in this picture, but again, in normal lighting, it looks much more like this. And it's something that I think if I were to do it again, I would definitely bevel quite a bit more. We know that when we add composite, there's, of course, opacifiers that we didn't have at the clinic. But nonetheless, if we get a really nice enamel bevel here, not only does that increase our bonding strength, but again, it does allow us that transition into that translucency here. So if I were to do this again, definitely main takeaway is bevel more. I was much too light on the bevel. But nonetheless, patient was happy with it. And here you can see this is him in function with some nice anterior guidance and not bumping into 8 and 9 too hard. He has a really nice anterior guidance here. So we were happy about that. And then here, there's just another close-up of the pre-op and post-op. So here, this is my first time doing kind of a quadrant dentistry. We have a 21-year-old patient, and we'll see her in the indirect video series. Here you can just see that we were replacing old fillings. So she had number 5 DO, number 4 MOD, and number 3 just occlusal. Now here you can see that there was decay that took me farther axial on the distal aspect of number 4 than I would have liked. Nonetheless, I definitely think I overextended here. I checked in with the patient, made sure, that she wasn't sensitive, and the tooth's been fine. It's now been about a year post-op, and I still ask her about how the tooth's been, and she's been happy with it. But nonetheless, just a takeaway for me, I think this went a little farther than I would have liked. But here we have, again, just the, intraoperative here, and this is post-operative here. So the number 3, pretty hard to tell. Now, I'm not crazy with how the margins are here on the composites. Pretty obvious. There's composite there. I think a lot of that had to do with time. But nonetheless, the contacts were very good. I was very happy with the contacts we created. Just again, spending more time polishing, I think we would have really kind of cleaned that up a little bit better. Nonetheless, the restorations have been holding up, and we've really worked with the patient on caries control. She's been doing a good job. Here, I'm pretty proud of this one. This is a pretty large class 3 restoration, as you can see. Here, we actually had to get some cord just to kind of get all the blood out of the way for when we were just doing the preparation. Now, keep in mind, this is an 80-year-old male. Now, we know that as patients age, we know that the secondary dentin continues to be laid down. And looking at the x-ray, we were looking very heavily. And the pulp actually is all the way down here somewhere. This is tooth number 27. I'm sorry if I didn't mention that. And so we knew we had plenty of room. Still definitely worked close with Dr. Masuma Chima to make sure that we didn't run into any pulp or anything like that. And here you can kind of see the margin went all the way subgingival. That's why we have to have that retraction cord in there. And after this picture, we did get some really nice isolation, believe it or not. And we needed to because you can see how bloody, the gums really got and how irritated they were. Now here you can see definitely some overhang. This wasn't at the final contour. We did clean up a little bit. Looking back on it, here you can see on number 26 there's some composite. There was composite here before. This wasn't my doing. Nonetheless, it would have been nice to just take that off. There's no reason to have that flash there. In fact, all it really does is just have a really nice, kind of breeding ground for bacteria. So if I were to go back, I definitely would have noticed that. And I think what this does is it highlights the beauty of why we take pictures, because we can be not only a little bit more self-critical, but also just kind of see things that we maybe missed intraoperative or during the operation. So nonetheless, the patient was extraordinarily happy with it. Now this is actually our darkest shade of composite, And this patient you will see in our removable series movies. And you'll see that this tooth is actually far brighter than all of the other teeth. This is shade D4 composite. Um, Again, talking with the patient really wasn't too concerned with how the tooth looked, shade wise, and he was just really happy with the results. So happy to get the result that he wanted. But overall, I think the contour was really nice. I think the blend here onto tooth onto filling looked really good, and patient was just really happy with how that turned out. So this again, sorry for the colors here, but patient presented here, and you see he has this. He's kind of the patient's occlusion was probably one of the most challenged occlusions that I've seen at school. And so you'll see he presented with these really jagged enamel edges here, and what he hated was this food trap right between 24 and 25. And so all we did here is we just kind of went in and I just added just some composite to get him a nice contact. That way it would stop the food trap. And then what I did, just because he mentioned how sharp this was, and he mentioned that no one did it for him, we just kind of smoothed out the teeth. So you'll see that way on his tongue, because he did actually present with minor cuts on his tongue. So we just kind of smoothed that out, and the patient was extraordinarily happy with it. Also, just a side note to both myself and anyone watching this, when taking pictures, if you're going to take pictures after impressions, which makes sense, just be careful to clean up any flash. You can see that this just doesn't present well, and I'm really unhappy with, kind of the lack of foresight of seeing this impression material. Nonetheless, just a takeaway for all of us watching this. Here, this is my first amalgam restoration that I did in the clinic. I did this one. This is the only amalgam I did on adult, and I did two back-to-back number I and number J DO-MO restorations, respectively, on an 8-year-old at the pediatric clinic. But nonetheless, just replacing an old amalgam. Patient's 84 years old. This is tooth number 17, so the access was pretty far. Patient already had an amalgam, was okay with an amalgam, and just looking at it, we had almost no shot of getting any type of banding or any type of isolation here. So talking to the patient was more than happy to receive amalgam, and here is all stages. So pre-op, intraoperative, and then here, this is the final restoration, which I was happy with, and so was the patient. This is the same patient. We'll see him for a couple of the slides, as well as some slides on the indirect. Here, patient called chief concern. You can see that he cracked a pretty large MO restoration on number 1. And so what we did here, this is just, preoperative, 2 pictures of pretty large slice. Here, this is after all caries removal. See a huge, pretty large restoration. And we were able to get by with composite. This is our final contoured restoration, which the patient was ecstatic with. Here, this is my mock rebs. And again, this is that same patient. Now, the patient does have, is a very difficult patient management patient. Again, the patient's 84. He does have a prostate enlargement issue, or at least his medical history is significant for that. And so he does leave to go to the restroom quite a bit. The patient is a retired military and does not have any problem expressing any discomfort or things that he finds that he's unhappy with. So just dealing with the patient, he is a little bit more advanced in terms of kind of patient management, but I think we did a pretty good job. So the patient actually did show up quite a bit late. He's about half an hour late for mock rebs. And so here we have, you can see the preoperative bite wing. You can see some decay here on the distal aspect of number 3 that went right towards the gum line. This is actually subgingival at this point. So here we had quite a large preparation design. I actually had to ask for an extension on every single aspect of the preparation, including going on to the entire lingual groove here. But nonetheless, the preparation did pass, as well as the restoration, which actually was 1 point away from perfect. The only thing that they didn't like was the occlusion was high, which we knew because we finished literally 30 seconds before rebs ended. So we were able to get in, and we were able to be graded, but just had to adjust the occlusion. And again, contact was perfect snap floss with the floss, and patient has been very happy with it. I've kept up with the patient, and he has been very happy with it. So this is the same patient. Patient on number 19 had an old amalgam restoration. Here you can see quite a large opening. And we know that with amalgam, the material does expand as well as condense. And so we do see this here. This is non-carious, but nonetheless, it does harbor, create a nice harbor for bacteria. And so we removed that for the patient, talked to the patient, and we thought that composite would be an ideal choice. Patient agreed. And so here, this is the preparation. You can see the nice MO preparation on number 19. And here's our final restoration. Patient was happy with that. Excuse me, this is tooth number 19. So this is tooth number 18 here. And again, patient was happy with what we got. So that's the end of our direct restorative portfolio. Again, below this video are the slides for the entire PowerPoint that we just went through. If you have any questions, comments, or concerns, please feel free to email me at j_barnett, BARNETT, at u.pacific.edu. Thank you so much, and I hope that you enjoy the rest of the portfolio.